All right, everyone, I have 12:03. So let's go ahead and get started. Welcome back to the Department of Medicine Grand Rounds. Today's speaker is sponsored by the Department of Medicine Health Equity Council. And so I'm actually going to hand it off to Dr. David Horn, who is our Associate Chair for Diversity and Inclusion for the Department of Medicine, and he'll introduce today's guest speaker.
Thank you, James. It's my great pleasure to introduce Dr. Deidra Cruz today as our DEI sponsored Grand Round speaker. Dr. Cruz is a professor of medicine in the Division of Nephrology at Johns Hopkins University School of Medicine. She received her undergraduate degree from the University of Virginia and her medical degree from St. Louis University, and is a graduate of the Osler Medical Training Program at Johns Hopkins, as well as having completed nephrology fellowship and a master's in clinical epidemiology at Johns Hopkins. Dr. Cruz holds appointments with the Schools of Public Health and Nursing, the Welsh Center for Prevention, Epidemiology, and Clinical Research, the Center on Aging and Health, and the Center for Health Equity, where she is deputy director. Dr. Cruz's work has elucidated root causes of the disproportionate burden of kidney disease among socially marginalized populations, addressed social and behavioral risk factors for adverse kidney outcomes through interventions, and inform guidelines for optimizing care processes for people with kidney failure. An elected member of the American Society for Clinical Investigation, Dr. Cruz has received numerous awards for her research contributions, including the 2018 Johns Hopkins University President's Frontier Award, a $250,000 award given annually to a faculty member who demonstrates significant academic achievement and the potential for transformative future work. Dr. Cruz is a former National Academy of Medicine Emerging Leader Scholar and was the inaugural Gilbert S. Oman Anniversary Fellow of the National Academy of Medicine. In addition, Dr. Cruz has received the W. Lester Henry Award for Diversity and Access to Care from the American College of Physicians in 2019. And the American Society of Nephrology honored Dr. Cruz with the Distinguished Leader Award in 2019. And she currently serves as the president-elect for the American Society of Nephrology. So I would encourage you all to give Dr. Cruz a warm virtual round of applause, and I turn it over to you. Thank you.
Thank you so much, Dr. Horn. Thank you for the warm introduction, and it's really, really great to be with you all virtually. Wish I could be there with you in person, but we will settle for the virtual environment. I'm thrilled that you all have this lectureship there, and really delighted to and honored to have been invited to be with you today. I'm going to be talking, as hopefully you can see projected on the slide here, I'm going to be talking from the subject of centering the margins to achieve kidney health equity. I know that through your group there, you have a focus on health equity, and I'll be talking specifically as it relates to kidney health, but certainly a lot of what will be discussed should apply to health equity across a number of different chronic health conditions in particular. So these are my disclosures, as well as those of the planning committee that I was asked to be sure to project. And so our objectives during our time together today are going to first be to understand this concept of centering the margins as a framework for advancing health equity. We'll go on to recognize some of the profound disparities that exist when it comes to chronic kidney disease, or CKD, and also some of the significant societal impacts that these disparities have. We'll talk about some of the potential root causes of these disparities, and then finally we'll identify some of the opportunities to mitigate disparities in CKD. So I've taken to, in the last few months or so, when I have the opportunity to actually sharing my positionality when it comes to whatever talk that I'm going to give. And this really, the definition of positionality is a social and political context that creates your identity and how your identity influences and biases your perception of and outlook on the world. And a number of journals, actually, particularly those focused on either health equity or sort of health services research, have actually taken to requesting that authors provide their positionality in the context of when they're submitting articles to those journals. And so to share with you all today my positionality regarding kidney health equity, which we'll be speaking about. Is that first I identify as a Black American who is a descendant of people who were enslaved. I have a family history of kidney disease, a pretty strong family history of kidney disease. I was born and raised in the rural southern US in a small town in Southern Virginia. So I have that perspective as well. I'm a nephrologist treating many people who have been socially marginalized. I'm trained as an epidemiologist, and so I tend to think about problems as well as solutions at a population level. And finally, I'm an optimist. And so while I'll be sharing with you certainly a lot of information and sort of data about disparities, which could lead many of us to have despair, in the end, I definitely believe that we have a lot of opportunity, and I'm optimistic about our opportunities to mitigate many of the disparities that I'll be talking about. And so to sort of jump right into this idea of centering the margins, this concept emerges from the seminal work of author and theorist Bell Hooks, who worked at the intersection of race, gender, sexual identity, class as well, and whose book that was called Feminist Theory from Margin to Center actually led to what is now referred to as the center margin theory. And essentially, this sort of simple depiction of the center margin theory lays out the essential aspects of it, including that those that are considered to be at the center of a society are those that are automatically accepted into society due to their race, their ethnicity, their socioeconomic status, their primary language, their sexual identity, or really anything else that grants them access without effort. And so again, so for these individuals, no effort is required on their part to remain in the center. Whereas those who are at the margins of society, these are going to be individuals who are not automatically included in the center due to many of these same factors that I mentioned a moment ago, and they or someone on their behalf must exert effort in order for them to be placed at the center of society. And so when we think about centering the margins, especially in the context of health and public health interventions, this idea really involves bringing those who've been systematically placed in the margins of society into the forefront of our efforts. And I think we've seen this a lot, especially in the setting of the pandemic, where we've seen that for many groups, it's been necessary for them to be centered in order for them to get what they needed in the setting of the pandemic, especially. And this really does apply quite broadly across both medicine and public health. So when it comes to socially marginalized populations and kidney disease, what we know is that there has really been tremendous impact. We know that Black, Hispanic, and Native American people have higher rates of kidney failure than do non-Hispanic white people. We know that racial and ethnic disparities that we observe here in the US are not fully explained by genetic risk variants. Many of you may be aware of what we've learned in the last couple of decades about this genetic risk marker of apolipoprotein L1 or ApoL1, which we know that estimates are that between 12 and 15% of people living in the US who have African ancestry will actually have the high risk genetic variants of ApoL1, which can place those individuals at greater risk of developing kidney disease. But interestingly, we know that even when when investigators have studied people with African ancestry who have the low risk genetic variants for ApoL1 and compared them to people who primarily have European ancestry, we continue to see profound disparities, really arguing again that while these genetic risk variants play a role, they don't completely explain the story of what we see even when it comes to racial disparities in particular. We also know that people with lower incomes have higher rates of chronic kidney disease as well. And a real key challenge in our field is that the majority of people who have chronic kidney disease are actually not aware that they have it, and awareness is often lowest among several of the very groups that we would be concerned about in terms of their risk of going on and developing kidney failure, which really poses a significant issue for those of us wanting to sort of stem the tide of these disparities. So when we look at what we've been seeing over time with respect to trends in disparities related to chronic kidney disease, in this study with Dr. Vart, what we were looking at was over the past 30 years or so, using data from NHANES, or the National Health and Nutrition Examination Survey. And essentially what we found was that the prevalence of chronic kidney disease had almost doubled among Mexican American individuals during that time period. And we noted in the study that while there were no real appreciable increases within group in terms of the rates of chronic kidney disease, the prevalence actually has remained fairly stable in the last 10 or so years. The gaps between minoritized groups like non-Hispanic Black people and Hispanic people, as compared to non-Hispanic white people, have remained quite significantly large. And also there have been gaps in terms of across economic strata as well. Now, I'm pretty sure that in this Zoom room that we can all agree that health disparities are inhumane. As it turns out, they are also tremendously costly, and both costly in terms of lives lost and also in terms of dollars lost. There was a recent study that just came out just within the last few days by Dr. Caraballo and colleagues that was published in JAMA that looked over a recent 22-year period and found that Black people in the US had experienced more than 1.6 million excess deaths and more than 80 million excess years of life lost as compared to white people, which is just even almost unfathomable to even wrap your mind around. And we know, in addition to this, that from data from the Office of Minority Health, from the Department of Health and Human Services, that it's been estimated that $1.2 trillion a year are spent due to the combined cost of health disparities and the subsequent deaths that are experienced by racial and ethnic minoritized individuals, here primarily driven by either inadequate or inequitable care that these individuals receive. And then we also know that about a third or 30% of the medical expenses that these same individuals incur are actually due to excess costs that stem from health disparities. And importantly, when we think about our standing in terms of health status and comparing ourselves to other countries around the world, it's been noted that the US actually spends less on social services than do other countries that are our economic peers, if you will. And in fact, we're the only country that spends more on healthcare services than we do on social services as a percentage of our gross domestic product. And scholars would argue that this is one of the key reasons why we don't enjoy the life expectancy and really other indices of health that many of the other higher income countries around the world tend to enjoy. And so there have been a number of conceptual models that have been put forward to help us think about what really are the underpinnings or the key drivers of why socially marginalized populations are at increased risk of developing kidney disease. This is a model that I like in particular because I think it captures the three key areas that really, again, underpin these inequities. So if I could call your attention to the right-hand side of the figure where we see issues surrounding uninsurance or underinsurance status. And of course, from that, people can then have limited access to healthcare and also limited or sort of inappropriate, in some cases, utilization of healthcare, and then can go on and develop some of the more clinical risk factors that we think of when we think of chronic kidney disease, such as diabetes and hypertension and obesity, and ultimately they can develop chronic kidney disease itself. In the middle of this figure are those issues that can stem from the experience of discrimination. And here thinking particularly of kind of two basket areas, one of the psychosocial impacts of experiencing discrimination and how it can lead to depressive symptoms, as well as some of the more biological impacts like chronic stress and including neurohormonal activation that can develop in that setting. We also know that the experience of discrimination can have impacts on health behaviors. So there's been a number of studies that have shown linkages between having that experience of prior discrimination and being more likely to have maladaptive health behaviors like substance use disorder, physical inactivity, and overeating. And these factors can ultimately lead, again, to people developing these more clinical risk factors that we think of for kidney disease, and also can lead to kidney disease itself. On the left-hand side are those factors that stem from residential segregation. Here, in particular, thinking about racial residential segregation, and including things like living in communities that have been disinvested, where there are poor educational systems, poor access to safe places to live, toxin exposure, as well as poor access to healthy foods. And again, these can lead ultimately to chronic kidney disease. We are going to spend our time on maybe highlighting these three areas here. They only gave me an hour today, but we'll talk about these three areas, including some of the work that my colleagues and I have done, trying to understand how these are at play when it comes to what we observe in terms of kidney disease. And I think importantly, though, what we now realize is when we think about that model and others that I just shared with you, what we now increasingly as a field recognize that that these are the sort of underlying root cause of these are structural inequities, including specifically structural racism. And here referring to how structural racism embodies the many ways in which a society fosters racial discrimination through inequitable allocation of resources and opportunities embedded within mutually reinforcing systems. So including the systems of housing, access to healthcare, and also food systems, which we often refer to these collectively as social determinants of health. But these are really increasingly, this idea of structural inequities and specifically structural racism are increasingly recognized as the major cause of race-based health inequities. And even some NIH institutes have put forward a number of activities and funding announcements really around this topic of structural racism, including one that I cited here that I had the pleasure of being a part of, that the National Institute on Diabetes, Digestive, and Kidney Diseases organized. So turning then to think about access to high quality and equitable healthcare and how that may play a role in kidney health disparities. As most of you probably know, over the last couple of years, our field has undergone a change in the very way that we recommend individuals get sort of diagnosed with kidney disease. And this, speaking here of the recommendation for a reassessing and then ultimately changing the equation that we use for estimating glomerular filtration rate over to one that does not include a race modifier, specifically a Black race modifier was included in that equation. And certainly this work, in the task force that was put together by the National Kidney Foundation and the American Society of Nephrology made this recommendation that all laboratories across the U.S. adopt this change. And certainly the hope is that that some of the concerns that many had about that previous equation, the least of which of being that the a socially constructed variable was being used in a biological sort of setting, is that one of the hopes is that this change may lead to earlier detection of chronic kidney disease among Black individuals, as well as earlier identification of those individuals being eligible for things like referral to kidney transplantation, or being eligible for some of the newer medications that we're very excited about that have been shown to help us to slow progression of chronic kidney disease. But certainly we know that that is an important change, and we're excited about it. But we know that change in the estimating equation certainly will not solve all of what we see with respect to disparities. One key disparity surrounds the timeliness of referral to someone like me, like to a nephrologist, for people who have advanced chronic kidney disease. This is work with my colleague, Dr. Purnell, where what we looked at was about a decade's worth of data, national data, looking at for people who had initiated dialysis. We did sort of a look back to see if they had received at least 12 months of nephrology care prior to initiating dialysis. Now, we focus on that 12-month period because there's a body of literature showing that patients who are seen for at least 12 months before needing to start kidney replacement therapy, they tend to have more opportunity for things like referral for transplantation, as well as consideration of home dialysis modalities, for those that are going to choose to start dialysis. And we know that there are also immense disparities in this timely referral, and we saw that those disparities had been sustained. When we looked at across different racial and ethnic groups, what we found was that for Black, Hispanic, and Asian patients, they were less likely than white patients to receive nephrology care within those 12 months prior to starting dialysis, and this was particularly the case for Hispanic patients. Now, for those of you saying, well, we also know, of course, that Hispanic individuals have lower rates and lower access in many cases to insurance, and could this finding of less timely referral to nephrology care be just a consequence of known disparities in access to health insurance? Indeed, when we did account or adjust for disparities in insurance coverage, we did certainly see that relationship between or that association between these particular racial and ethnic groups with being less likely to receive timely nephrology care was attenuated. But we did continue, though, in particular, to see this among Hispanic individuals, where even in the most recent time period, they were 10% less likely to have been seen at least a year ahead of initiating dialysis than was the case for white individuals. So what about in systems where everyone has equal access to similar insurance and therefore, in theory, equal access to care? And I understand that a number of you probably tuned in work at the VA there in Seattle. So in this study, they looked at sort of just that. They looked at a population of veterans who were being cared for in the VA system, and they were focused on those veterans who had stage 4 chronic kidney disease. And what they looked at was what proportion of them were being followed by a nephrologist. And they found that, if anything, the Black and Hispanic veterans were more likely. They had higher rates of having had a nephrology visit. I believe this was focused on having had a nephrology visit within the prior year. But they did find, though, that still these very same groups were still more likely to progress to more advanced chronic kidney disease, to stage 5 CKD. Really, I think highlighting that access to healthcare, including access to specialty care, is probably necessary or beneficial, but is not sufficient really to mitigate progressive chronic kidney disease, particularly the disparities that we see in progressive chronic kidney disease. So turning to residential segregation, importantly, residential segregation is among the most potent forms of structural racism. And this really has everything to do with practices such as the practice of redlining, which many of you are likely familiar with, which was one by which banks and other organizations really in a position to make loans to individuals who may have been trying to either purchase a home or start a business would actually restrict those loans to in areas where they would basically not lend to borrowers who were in communities where either the residents were predominantly Black individuals, or in many cities across the country, they also had discriminatory practices against religious minority groups, including Jewish individuals. And so sharing with you here a redlining map of both Seattle as well as Baltimore, where I sit, of course. And these maps are from almost 100 years ago, so around the 1930s. And notably, just to orient you, so the red areas, those are the areas that would have been considered hazardous for banks to lend to. Those that are in kind of a yellow shaded area are those that were considered declining areas that might, again, be likely to be hazardous soon. Whereas those in the green were considered the best or the most optimal places to lend, and the blue areas were considered still desirable, so still kind of desirable areas for these banks to lend to. So this was the major redlined community in Baltimore back in the early 1930s. And Baltimore was actually one of the first cities in the US to actually adopt this discriminatory practice of redlining, such that many cities across the country actually modeled their practice after what was being done in Baltimore. So what about Baltimore today? So when we look at Baltimore today, what we actually find is that even 5 miles makes a world of difference for health. What we see in this area that's in the northern part of the city, the Roland Park or Poplar Hill community, is that around 83% of the residents are white individuals. The median household income is relatively high for here, but I know not that high for Seattle, but it's around 104,000. The unemployment rate is quite low. The homicide rate is essentially non-existent. The life expectancy in this community really rivals that of places around the world like Japan that actually have a much longer life expectancy than the average here in the US. And the death rate from heart disease is actually low in that community. Whereas if we look at the Madison or East End community, we see that 90% of the residents are Black individuals. They have about a quarter of the median household income of Roland Park. They have an unemployment rate that's more than 10 times that of Roland Park. They have a high homicide rate as well as a 15-year lower life expectancy and a death rate from heart disease that is more than 3 times that of Roland Park. And you'll probably recall this was the same area, the same sort of community that had been redlined now, again, nearly 100 years ago, really demonstrating the effects are still long lasting. So one of the really kind of key things that are shaped by discriminatory practices like redlining and certainly continued residential segregation is this issue of just of housing and having a safe place to live. This idea of housing insecurity is an understudied area in sort of kidney health and kidney disease more broadly, but is one that with my colleague, Dr. Novick, we tried to explore in a Baltimore-based study where we examined this question of, are you able to afford a home suitable for you and your family? And found that around a third of the participants in this study were not able to afford a suitable home. And when we looked over time, this was around 3.5 years of follow-up, what we found was that housing insecurity was associated with newly developing incident albuminuria, so newly developing protein loss in the urine, but wasn't associated with some of the other kidney outcomes that we examined. But this did tell us that that experience of housing insecurity could certainly set people on the path to that one of the earliest markers that we see in terms of kidney disease. We were also curious about the experience that people already with CKD might have if they are experiencing housing insecurity or housing instability, as we referred to it in this study. So we examined a group of participants who, around 350 of them, who already had CKD, looked at similar questions, the one about having being able to afford a suitable home, as well as this question surrounding had they had difficulties making rent or mortgage payments, and found that, again, that about 38% of them were having those challenges. And then what we were curious about was, well, how does that relate to their care-seeking practices? How often they're coming in for routine medical care. And we found that about a quarter of them had said that they had delayed or postponed medical care even when they otherwise felt like they needed it. And indeed, if you look at the table here, indeed, those who were experiencing housing instability were that the experience of housing instability was independently associated with postponing medical care, which probably doesn't surprise you, but for us, really, again, pointed to a group that's going to be at very high risk of not receiving the type of care that I think many of us would want to deliver to them. So another issue that has been shaped by historical practices such as redlining are those surrounding healthy food or neighborhood food availability. This was a study done in Baltimore, but certainly findings like this have been replicated in multiple cities around the country, where here in the box that's here in this map is this is surrounding Baltimore City, and then outside of that box is Baltimore County. Maybe I should use a mouse over here, is Baltimore County. And essentially what the investigators found was that there was a greater amount of healthy food that was available, indicated by the size of the green circles, in those communities where the residents were predominantly white people, so indicated by the darker gray shaded areas, as compared to those communities where the residents were predominantly Black, so people indicated by the white shaded areas here. Again, something that's been replicated in numerous settings. Another related but slightly different issue is that of food insecurity. And so one definition of food insecurity is that it's a lack of consistent access to enough food for an active, healthy life. What we know in the US is that non-Hispanic, Black, and Hispanic individuals experience a greater burden of food insecurity. And we know that food insecurity tends to spike during times of economic downturn, so including, as depicted here, during the Great Recession, so in 2008, 2009. And we know that in the setting of the pandemic, there have been increases in food insecurity as well. This was some projected numbers from Feeding America, which tracks the burden of food insecurity in the US, where you can see that it was projected that about 1 in 5 households, particularly in these top 4 states that are listed here, that were expected to experience food insecurity in the setting of the pandemic. So what about food insecurity and health outcomes? So it's been shown for sure that food insecurity has a relationship to greater risk of diabetes and hypertension, as well as, particularly in the case of diabetes, risk of being hospitalized with excursions of glycemia. So either particularly hypoglycemia, but also hyperglycemia as well. In the case of kidney disease, we've done some work around this. This is my colleague, Dr. Banerjee, who is out west at UC San Francisco, where we used National Health and Nutrition Examination survey data to identify a population of people who already had chronic kidney disease, and then we stratified them by whether or not they were experiencing food insecurity or not. Or were food secure. And essentially what we found in terms of looking over follow-up was that those people who were experiencing food insecurity were more likely to progress to kidney failure than those who had food security. And when we went on to account or adjust for factors that could have a relationship with either food sort of dietary patterns and or other sort of, and also some risk factors for kidney disease, we were encouraged, I think, in many ways in finding that when we accounted for nutritional factors, that we were at least able to statistically, anyway, explain away this association. So really, I think underscoring that even though food insecurity can really be a marker of, for many people, of them making trade-offs between sort of perhaps spending money on medications or spending money on their rent or their utility bills instead of purchasing food, right? So and so it can be just a marker of financial strain in many ways. It was interesting to find that at least the suggestion that the mitigation of the nutritional portion of that experience of food insecurity might be one way to lower the chances of people with chronic kidney disease progressing to kidney failure. Now, we did this work around the same time that we and others really were also finding that there were particular ways of eating or dietary patterns that were that at least had an association with better outcomes with respect to kidney health. Essentially finding that patterns like the dietary approaches to stop hypertension dietary pattern, or DASH dietary pattern, which is rich in fruits and vegetables and whole grains and low-fat dairy foods, as well as dietary patterns, others related that are, again, rich in fruits and vegetables that contain or present, if you will, less acid for the kidneys to handle, or these lower dietary acid load dietary patterns, were associated with favorable outcomes when it comes to kidney health, including things like being less likely to develop chronic kidney disease in the first place, and being less likely to have that CKD progress to kidney failure. And so these are what we were finding through a sort of a series of studies. And it was our desire to then center, if you will, marginalized Black individuals with kidney disease risk in our work, really trying to put together these findings that we were having through these largely these epidemiologic studies. We, in some qualitative work, were able to better understand some of the real challenges that would stand in the way of sort of supporting Black adults, which were our focus, in trying to make dietary modifications that might lessen their risk of developing kidney disease. In this study, we conducted focus groups of a group of again, Black adults who had low incomes and had a first-degree family member with kidney failure. And we asked these individuals a series of questions about, what did they think would need to happen to actually help them to lower the chances of them developing kidney failure, like their family member, with a real emphasis on diet and food access. And so one of the themes that came out of the discussion was that healthy foods are expensive and they're unavailable in certain neighborhoods. One participant said, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. So they were, really highlighting this challenge. The participants also noted that unhealthy foods were more convenient to prepare or to access, in their view, and also that unhealthy dietary practices had been a lifelong habit that they worried would be difficult to break. Now, in a separate study using a participatory research discipline called photo voice, which maybe as the name implies, involves training the participants to use cameras to photograph things in their environment and then come together, usually in sort of focus group settings, to discuss what is seen in those photos, or what is shown is usually the term we use, what is shown in those photos. And so these are some photos that participant P. Mosley brought forward to the group and said, this vacant building, now people start sitting and drinking in front of it. This is an eyesore. People leave trash, which attracts rats. This building could be turned into an Aldi's, which is a grocer chain here in our area. Discriminatory practices against Blacks don't allow them to buy lots and buildings. It's not affordable to a lot of people, so they give up. People want to do good, but don't have the money. We can have liquor stores, but not a market. So they were, again, sort of highlighting what they were seeing. This participant, L. Davis, had developed a garden at their home, and where they were sort of both certainly providing food for their own family, but also for others in the community as well. And so they said, I tried something I saw out at a store at home. It saved money and it was good. It's complicated to try shopping. People with cars can get around. People in the neighborhood have no access. I try to help when I can. Concerns about crime and safety. If it was easier to get stuff, crime would decrease. And so, we were here learning a lot about both certainly the barriers that this population of individuals that we wanted to develop an intervention for were facing, but also a number of assets that they had as well that we felt like we could build upon. And so we recently wrapped up a clinical trial that actually was aimed at trying to address some of these real world obstacles to healthy eating that Black Americans often face. This was a 12-month, 2-phase, community-based randomized trial for 150 individuals, where our hypothesis was that the delivery of nutritional advice to adopt a DASH-like dietary pattern plus $30 per week worth of potassium-rich foods would ultimately lead to a 20% greater reduction in urinary albumin excretion, so reduction in albuminuria, and also improvements in blood pressure when compared to the provision of a grocery gift card without the nutritional advice that the other group was receiving. And so this we presented these at least the first phase of this study's findings at American Society of Nephrology Kidney Week, and the manuscript is in progress. This study was a community engaged research study where we had numerous community partners, including both our grocer partner ShopRite, as well as our very engaged community advisory board that's pictured there. So these are the 2 phases. So we randomized participants, and then we, in the sort of the top level, we had one group who was our self-directed, or as we refer to it, our S- diet group, that in the first 4 months of the study received a gift card that was worth $30 a week. So they ultimately got about $480 in gift cards. And at that time, when they were randomized, our study coach, who's a certified health coach, reviewed the DASH diet brochure with them, but otherwise didn't provide any extensive guidance around what they should purchase with the gift card. And then in the second phase of the study, the participants in that group were not provided with a food allowance. They were told, please follow what you read in the DASH brochure, but otherwise were not. It did not receive the gift card at that time. And whereas in the other arm, the dietitian-directed coaching, or C- diet group, this group in the first 4 months, they received support for actually ordering $30 a week worth of what we refer to as 5+ foods that were delivered to their home. And they also received weekly, these brief calls with the study coach, where they would discuss things like, definitely placing their food delivery order for the next week, but also tips around how to incorporate those foods into that participant's way of eating, and really kind of helping them to sort of work around the process of making these dietary changes. And then in the second phase for that group, they no longer received the food allowance, but they did continue to have telephone visits with the study coach, but at more spaced out intervals, not weekly, but sort of less frequently. So this was our primary outcome was 4 months, which I'll share with you a little summary of the results of that shortly. Just for those curious about the actual components of the intervention, we were again focused on of really trying to get them to consume high potassium foods. And so these are some examples here. What we were targeting were 5 servings of fruits, vegetables, nuts, and beans. And we would provide via the order that we supported them in placing, we would provide around 17,000 milligrams of potassium that was ordered, with a goal of trying to get close to the DASH diet target, which is about 4,700 milligrams per day. So that's what we were trying to get to, understanding that this was on top of the other foods that they would be purchasing and consuming. And so with the grocery orders, which, I learned a lot about groceries during this study, but one of the things we learned is that $30 worth of fruits, vegetables, nuts, and beans comes out to about 6 plastic bags worth of groceries. And in those bags, we would include for the participants these tip sheets, which included, things that sort of basic introductions to this way of eating, but also things like, how to eat the 5+, how to eat 5+ for folks who don't cook, because we certainly had discovered that a number of our participants didn't cook at all, and so we certainly needed to provide some guidance around that. And so, just to summarize what we found, we essentially found that coaching to follow a DASH-like dietary pattern plus the healthy food provision led to some significant within-group improvements in both diet quality, so things like the number of servings of fruits and vegetables, the amount of potassium that they were consuming, as well as within the coaching group, they had significant improvements in albuminuria. We did find, when we compared the groups, we did find that coaching was superior to the food subsidy alone for improvements, again, in that overall dietary quality, and also albuminuria lowering, but specifically among those participants that were losing lots of albumin in their urine. So people with albumin to creatinine ratios of greater than 300 had a particular, we saw a particular impact there. So, really building upon that work and others, it's been important for us to try to advocate for policy changes that both, and I'll share with you some of that, but both in the space around food and thinking about food access, but also more broadly when it comes to policies relevant for kidney health. With the findings from that photo voice study, we held a symposium that we called Seated at the Table, where we invited policymakers, urban farmers, educators who are teaching children how to about agriculture, and others really to come together to think about what policies and practices in some cases need to be changed and reshaped in order to improve the food environment here in Baltimore. In other work, we've tried to call attention to federal policies in many cases that impact the care of people with kidney disease, including work around the experiences of dialysis patients who are experiencing homelessness and calling for consideration of programs such as permanent supportive housing for this particular population, as we've seen with some other clinical populations. And so just to summarize what I've shared, disparities in chronic kidney disease are certainly profound, and they have significant societal impact. Some of the root causes of these disparities include limited access to high quality healthcare, discrimination, and also the downstream effects of residential segregation. Achieving kidney health equity, at least in my view, will require a commitment to centering the margins by designing interventions and advancing policies that draw upon the strengths and also address many of the needs of historically marginalized communities. So I want to end by thanking the participants of the studies that I presented, as well as my colleagues at these teams and centers, and in particular to thank my colleagues at the Center for Health Equity, where much of the work that I shared with you took place. And I thank you for your attention and the invitation.
That was a wonderful talk. Thank you so much. I really learned a lot and enjoyed it, and appreciate your advocacy.
Thank you.
I'll ask James to help me with any questions, but maybe I can get it started. Just broadly speaking, I don't mean to put you on the spot, but you positioned yourself, amongst other things, as an optimist. And so, what about what you presented gives you hope for the future? And you'll have a nice bully pulpit as the ASN president, hopefully, to bring some of these things to happen.
Yeah, so thank you. So a few things give me cause for optimism. One of them, honestly, is the growing number of people working on these just enormous problems. I'm definitely inspired by the learners that are interested in these topics in sort of in our spaces and in medicine. And also, colleagues who are already more established researchers who are gaining interest around these topics. So that gives me hope. I also am encouraged and optimistic, as I mentioned. A lot of the type of work that I've been engaged in, and I think for any of us working in the kidney space, we are just inextricably linked to health policy because of the provision of coverage of our patients who have kidney failure, that they become automatically eligible for Medicare. That means that we are just constantly, sort of in sort of lockstep with policymakers and thinking about how we can do better by those individuals that really our entire populace is invested in. That's something we don't talk about enough, is that because regardless of whether a person is 15 years old or 85 years old, they automatically become eligible for Medicare if they develop kidney failure. So we're all, as a society, invested in many ways. And so I think that gives me hope too, the interest from policymakers in this issue of inequities as well. So I will maintain my orientation towards optimism.
We do have some more time for questions, so if folks want to
Sure.
put their questions in the chat. But one thing I was curious to ask a little bit about is, it sounds like you mentioned that the Division of Health Equity was really key in sort of creating this initiative and working with you. And as we are sort of expanding our own division of equity within our department, can you just tell us a little bit more about how your division's structured and how that all came about?
Well, sure. So we are not a division. So we're a center. So we're a Center for Health Equity at Hopkins. I'd be interested in hearing your story about becoming a division, but we have been around now for going on 13 years. So we are one of the more mature centers of health equity around the country. And the way that so I think importantly, our center, which is led by Dr. Lisa Cooper, who is a general internist, while I think a lot of groups who have either centers or institutes for health equity, particularly the earlier ones, had focused a lot on sort of documenting health disparities, which we certainly do as well. We have been a center really focused on interventions. So we do a lot of testing interventions through community engaged trials. So partnering with various partners. Sometimes they're certainly community members. In other cases, our partners are healthcare systems, right? Or people, clinicians who are in practices, for example, serving at federally qualified health centers and so forth. And so we focus a lot on interventions. And so that 5+ nuts and beans for kidneys is a trial based at the Center for Health Equity, and built upon a pilot study that was also conducted at the center called 5+ Nuts and Beans. That was not necessarily focused on people with kidney disease, but focused more on people with hypertension. But that's one way. And then it places us in a position to engage with policymakers, especially local here in Baltimore, as well as state policymakers who have had great interest in the evidence that we're able to generate through these trials, because we can then point to them and say, hey, if this policy was different, we could do this differently, or we could do this better. So that's been helpful for us. But we'll have to talk offline about how you all got a division of health equity.
I should say I misspoke. We don't have a division. We have,
okay.
I guess, and I don't even know that we technically have a center yet. We have sort of a burgeoning group housed within the Department of Medicine.
Oh.
There may be a better academia speak way to describe it that I'm misquoting. A few other just questions here in the chat. One was about food really being inextricably linked to culture and family. And as you were doing this work, was it ever challenging when folks maybe had diets that were at odds with what their cultural background or beliefs were?
Yeah, so I think we try to be sensitive to that. So through a few ways, we did focus on our study was focused on Black adults, and certainly not a monolith, that group, but we did try to then, if we were providing recommendations around particular recipes, we would try to provide examples that might be considered culturally appropriate, right, for those individuals. And then we also just honestly asked people, when we were in the trial that I mentioned, we were saying, hey, we've got these 60 different options that you have for fruits, vegetables, nuts, and beans. Which things do you like? Which things have you never tried but you'd like to try? And then we would try to work with him to figure out, well, how would you incorporate that into, maybe the types of foods culturally that they may enjoy. So I think we approached it, with humility, understanding we wouldn't know exactly how people would want to eat, but with a lot of offerings that hopefully could be adapted to work within their style of eating.
Awesome. And we have time for one more question. This really was looking at the fact that a lot of the therapeutics that we think about now as being beneficial in preventing progression of kidney disease came out of trials that were biased. So do you ever worry about then sort of taking those and applying them in the population who clearly needs them, but maybe weren't included in the initial trials, so weren't shown to demonstrate benefit?
Yeah, so you said a lot of these newer therapies. Is that what you're referring to? Yeah, so I do think this is where we really do need more implementation research to understand, we may know in sort of, particularly in these highly controlled settings, in some cases where different therapeutics have been tested, but understanding like, okay, now let's take that therapeutic and then let's figure out how to just get it for people from an insurance standpoint, get it in their hands, find out if they tolerate it, and can sort of maintain the therapy with it. And yes, and also understand the effectiveness in broader populations. I think we need more work like that. I definitely think there's certainly a number of people who are doing work to try to expand how inclusive our clinical trials are in terms of including, for example, people from racial or ethnic minoritized groups in those trials. But I think even before we get to achieving that, we should also be, or while we're working on achieving that, we should also be working on more of those implementation type studies. Should I try this one, about the 1.2 trillion?
Sure, yeah.
Sure.
I see that one, yeah.
The last one, sure.
So thank you. Yeah. So where do those costs? So usually the costs end up being surrounding like acute care costs. So you would think that so who's responsible for them, right? So it would fall then, certainly can fall on the hospitals, but it's then going to fall on public payers, right? So Medicaid, in many cases as well. And then obviously, and yes, the public, because of our sort of tax contributions, it ends up falling on us too. So really, we're all whether we are from one of these socially marginalized groups or not ourselves, we are actually all being harmed by these health disparities.
Well, Dr. Cruz, I would like to just thank you again. And it was such an important reminder about how the differences we see between people, diverse peoples, is it's not genetics. It's the social determinants. It's the redlining, and really just thank you for your important work.
Thank you so much for having me. Really enjoyed being with you.
All right. Take care. Thanks.
Thank you.
Bye-bye.
Thanks, everyone. We'll see you back in 2 weeks for our next grand rounds. Coming up on our last two for the academic year.